the perioperative management of the podiatric patient, I think a lot of us think of think about podiatry, and we think of the clinical aspect of things, but I think it's really important to think about how we can perioperatively manage these patients in a safe and effective manner. And so I have no conflicts of interest to disclose. A brief roadmap of where we'll be going. So first, I want to talk about how we can go about preoperative optimization of these patients, intraoperative considerations, and then how some things that you might come into contact with during the postoperative period. So some objectives of this talk would just be, I want to understand the importance of the American Society of Anesthesia guidelines and how these apply in guiding podiatric surgeons. I want you to understand what essential information to gather preoperatively and how this may impact your operative considerations, and then understand the intraoperative considerations when we go to pursue a podiatry surgery, and then understand what we have to come into contact with and how to manage different complications postoperatively. And so, when we go back and think about the American Society of Anesthesiology requirements and recommendations, we learn about these all throughout in school. And, one thing, it's really important that they do recommend that we obtain information from a wide variety of sources. And so, whenever you're evaluating a patient for surgery, we want to understand the medical records, patient interview, and then physical exam, and then obtain medical tests and evaluations so that we can appropriately prepare our patients for surgery. And so ultimately, it's going to be that collaboration between the surgeon, the anesthesiologist, and the primary care physician. So, for a lot of us, this likely will go ahead and be a review. But the ASA, it is 6 different categories based on the severity and variety of comorbidities present among patients that we take for surgery. And so this is particularly important because when we go to take patients for maybe an elective procedure at an outpatient surgery center, they may only be able to take patients that are ASA class 1 or 2. And then some hospitals, or surgery centers will not take the patient if they're not that classification. So that in and of itself, is important to consider. Also, if these patients have a higher ASA, it's going to be really important that we optimize them prior to surgery. This was a really interesting study that evaluated the perioperative mortality of patients, elderly patients. And, we won't go into the detail with this, but, when we look at the conclusion that they had, what put these patients at a high risk of mortality, it was advanced age, prior admissions, and procedure invasiveness. And so like a lot of these patients, that we do surgeries on, have the run the risk of, having a high risk of mortality. So it's really important that we optimize these patients perioperatively. So preoperatively, what are we going to make sure we do, right? So first and foremost, we're going to want to make sure that we understand the H&P, as well as what comorbidities will we have to optimize during the perioperative period. And so for a lot of our patients, this is going to be peripheral vascular disease, right? So for our patients, we're going to want to make sure that we optimize them, especially if it's an elective surgery as far as peripheral vascular disease goes. And also, the patient has peripheral vascular disease, there is a high chance they might have central coronary artery disease. So it's really important that we optimize them from that perspective as well. And so perioperatively, what will we want to go ahead and make sure that we keep an eye out for? So so first and foremost, we want to make sure that we optimize them from a cardiopulmonary focus. So from the perspective of cardiovascular standpoint, we really want to ensure that they're optimized. And so if that requires a referral, we want to make sure that we do that prior to the surgery. And again, for these complex cases, we're going to want to make sure that we collaborate effectively with the anesthesiologist prior to the procedure. A lot of our patients are going to have diabetes. And so the number that we look for typically is going to be that A1C less than 8 for elective foot and ankle surgery. And then as far as the nutrition goes, there have been some studies that have described serum albumin and prealbumin as being factors that can contribute to poor healing. And so that is something to kind of monitor. And obviously, if we're working patients up for infection, we're going to want to ensure that we do the appropriate workup. So that's going to consist of the ESR, CRP, white blood cell count, and then hematologically, you're going to want to ensure that we have a hemoglobin that's greater than 7. If not, and it's an urgent procedure, we're going to go ahead and transfuse. Platelets, we're going to want to make sure that they don't have thrombocytopenia. And if it's less than 50,000, we're going to consider canceling the surgery while we optimize them from that perspective. And then the INR of less than 1.5, that's typically what the goal is when we're taking them for surgery, because if not, we're going to run the risk of bleeding complications. And so the recommendation typically is to cancel if it's above 3. And so, we learned that the complete metabolic panel is going to be extremely important for patients. And so what do we look at when we're looking at the CMP? Well, we want to look at the electrolytes, right? So we want to make sure that they don't have any significant hypernatremia or hyponatremia, hypokalemia or hyperkalemia. And this is from the African Journal of Anesthesia and Analgesia. And these are kind of the cutoffs that they use when considering postponing surgery. And I think that these are good values to use as a basis as well. And so, it's important that no man is an island, right? No podiatrist is an island. So we really have to make sure that we optimize our patients the best of our ability. So if they have a cardiovascular problem, we're going to want to consult cardiology. Rheumatologic issue, consult rheumatology. And then, if they have a transplant, we're going to want to optimize them with the transplant team, so on and so forth. So this is a really good chart that shows kind of the preoperative workup that we're going to want to do for patients with different comorbidities. I just put this in for a reference for you to refer to whenever you're taking these patients for surgery. And so, wide variety of comorbidities and the different studies. And so just a public service announcement, the worst thing that a surgeon can do is show up the morning of surgery and realize that, one's electrolytes are abnormal or, the hemoglobin's below 7. And so, just a public service announcement for those patients, for those residents or, any type of podiatry surgeon that's taking patients for surgery, make sure that we monitor these closely so that we don't go ahead and, have any surprises the morning of surgery. So if we have to optimize something, we want to do that. So vascular disease. So obviously, prior to taking the patient for surgery, especially if it's an elective surgery, we're going to want to ensure that we fully understand the picture of the vascular disease. And so as we know, the International Working Group on the Diabetic Foot every 4 years comes out with recommendations. And they say that, there is no one study that we can use to go ahead and to predict healing. And so it's a combination of things. And so, we're going to look at their ABIs, we're going to look at their TBIs, we're going to look at the toe pressures, and then we're going to look at the TCPO2s, all of which will be things that will kind of help us determine the patient's ability to heal. And so all these things are, important that we consider prior to taking the patient surgery. But it's important to note that if a patient is infected, we go ahead and manage that infection first. So, manage the infection first, whether that be an IND, an open amputation, and then follow that by the vascular optimization. All right. And then, so this was a really interesting study. How's it going, Dr. Evans?
Hey, Chris, I'm good. How about you?
Good. you know what? I didn't know if you were going to log on or not, so I just went ahead and started another presentation. But if you think you have plenty of time, I would love to share here.
Oh, hey, whatever you would like, man. I'm here for you.
Okay, perfect. You know what? Why don't we? This is actually a perfect part here. So we talked about a little bit of preoperative optimization, and I think this is a great point because I was talking about vascular optimization to kind of kick it over to Dr. Evans here.
Thanks, Chris. Am I coming across okay to you?
Yep.
Okay, cool. Hey, well, I want to thank Chris and the whole U of M department there for allowing me to share some of my interest in peripheral arterial disease with you, something that we all deal with on a regular basis. And I've just had the good fortune of being able to work with a number of people around the country over the last 10 years to learn more about this. And I'd like to share some of my insights and what I think is important, especially to our profession. In 2020, the American Heart Association and American College of Cardiology reached out to the APMA. They were in the process of revising the 2016 PAD guidelines, and they wanted a representative from podiatry on that writing committee. This was kind of big for us because APMA had never been asked to participate in a project of this scope. So it was pretty cool. So what began as I thought was going to be about a 6 or 12-month process turned into 4 years uh, of weekly Zoom meetings for the first year and a half, and then biweekly, and then monthly, and then there were revisions and all that kind of stuff. But finally, earlier this year, it was published. And I'd recommend that really all of our profession had a chance to look at them because podiatry has an important part within these guidelines. It's nice to be recognized by some major organizations as to our importance that's not just in wound care, but in other areas too. So I had the privilege of working with about 30 of the top vascular physicians in the country uh, and me coming together on these guidelines. And again, I'd like to share a number of things that I learned that I really wasn't aware of before. We know PAD is a global problem. It affects over 200 million adults around the world. And these, in the US, it's about 8 to 10 million is what you're going to see published. Well, the problem with that is these numbers come from demographic and diabetic data from around 1985, but they keep using the same numbers over and over again. A recent analysis was done by a researcher named Mary Yost, who has the numbers closer to possibly 26 million of us are dealing with PAD in the US. There's a couple of terms that you're familiar with, the critical limb ischemia, CLI, and the newer term, chronic limb threatening ischemia, CLTI. They both mean the same thing, although they're suggesting we use the CLTI more. This is the chronic level of PAD, and its severe level that affects a little over 10% of our patients with PAD. And the costs are astronomical, with well over $21 billion every year spent to treat this. And about 1 out of 5 patients are what we consider polyvascular, meaning they have more than one vascular bed involved with this. So when it comes to atherosclerotic changes and vascular disease, we talk about there's 3 major beds. There is the heart, which is the one we have the most research and treatment options for. There's a cerebrovascular system in the brain, and then there's the peripheral arteries of the legs. Now, when I was in school, we learned that arteries were the same. Basically, they have the same anatomic structure. But apparently, there's some differences depending on where they're located. Patients who have PAD, almost half to up to 90% of them will have coronary disease also. But the reverse is not true. Less than a quarter of patients with coronary disease will have PAD. So there's got to be something different in the anatomy or the location and the physiology of how atherosclerosis develops in these legs. Now, most of us are concerned about the legs primarily, But if you got a patient with PAD, the odds are they probably have some coronary and possible cerebral vascular disease too. So it would be important to refer them out to be evaluated just to make sure they're okay so it's not missed. Because PAD is often missed as a diagnosis. I bring this up because there's a very important point that I'd like to make that I was not aware of at all before I started doing research on this. When they look at the anatomy and histopathology of atherosclerosis in the legs, it appears to be different than that of the heart. Narula has published a number of papers looking at amputations of the leg, and he compared above knee amputations versus below knee amputations. And they found that above knee amputations, the histologic changes in the arteries was very similar to that of the heart when atherosclerosis develops. There was an atherosclerotic plaque that would develop. There'll be calcification of the medial vessels aspect of the arteries, typical of changes around the heart. But when they went into the legs, they found these findings to be in the minority when they went below the knee. Most of those changes were chronic thrombotic occlusions there. Now, one of the reasons this is important is because most of the treatments we've had for PAD in the past in the legs were done from corollaries of research that were done on heart atherosclerosis, where antiplatelet therapy is extremely effective. Problem is, in the legs, it was not as effective. And that has always been a problem that we, until recently, really didn't understand why there would be a difference or why one treatment that works in the heart and the brain would not work as well in the lungs. And we'll talk about that a little more in a minute there's a section I'd like to go on talking about pharmacologic therapy of that. But I think most of us are aware of the risk factors for PAD. For every decade you live past age 50, there's a significant increase in the risk of PAD. Diabetes and smoking are the real risk drivers for developing PAD, but followed by hypertension and lipid disorders, along with renal insufficiency and inflammatory conditions. So it kind of covers the gamut here of what can lead to PAD. Problem is, the presentation of PAD is often missed. 2/3 of the patients are either asymptomatic or have atypical pain symptoms. And most of the time, we don't diagnose PAD until there are some degree of ischemia that we notice. Either there's claudication, or we have wounds that won't heal, or we see gangrenous changes, or a cold foot, something like this. But when you look at claudication alone, less than 15% of those patients present with a typical change. Meaning, if you wait for these signs of ischemia to develop, you're going to miss 90% of the cases. And this is a major problem we have, less so with us as podiatrists, but certainly with primary care. But I have to say, it's real easy for us to miss this problem too. PAD, it seems, is something that we don't diagnose until they become symptomatic, which means they've got degree of ischemia. Problem with PAD is it begins to develop in our teenage years, and it gradually worsens throughout our life until we die. PAD really never gets better. At best, we can either slow it down and maybe make it a little bit better or try to work with it that way. But it gradually gets worse, but we don't notice it until it reaches a critical stage of ischemia, which is kind of a lousy way to treat things. I mean, if we didn't treat heart disease until people had MIs, we would be considered below the standard of care. But PAD seems to be looked at differently. So we need to be more aware of the disease state. One of the nice things about the new guidelines were they defined 4 different subsets of PAD. The asymptomatic, where you may have a functional involvement, but there's really no specific ischemic symptoms. There is the larger stage of chronic symptomatic. Now, this is where you've got some ischemic symptoms. Usually it's claudication, but for us, it would also be wounds that don't heal well, or as they would be expected. Then we get into the more severe stages with the chronic limb-threatening ischemia, which the patient very well may need an intervention to save the limb or the life. And the fourth stage is a little bit out of order. It's the acute limb ischemic stage, heart attack of the leg, the surgical emergency of this. Now, one of the things the guidelines have pointed out, that podiatry is important in all the stages of PAD. The thing is, our responsibilities are different depending on the stage. But there are three things that carry through pretty much for podiatry throughout all of these. And one is we're responsible for awareness. Most of us, we're the people who are going to diagnose that PAD is a problem and refer them into specialists who would treat it appropriately. Besides that, we're involved with education. We're teaching our patients about PAD, the danger of it, and the importance of follow-up with it. But it's not just the patients, but it's the patient's family. And quite often it's primary care doctors that are treating them also, because PAD is not in the top 13 things that they're looking for in these patients. The next is monitoring. Once a patient has PAD, you basically are going to be the vascular specialist's eyes and ears on the ground when they're not in the clinic or the cath lab. Really, for the rest of their life, once a patient has a diagnosis of PAD, we need to be watching them. And finally, protection. This goes a lot into wound healing and treatment of infection, offloading, whether it's orthopedic offloading with inserts or shoes, or surgical offloading, where we're changing the structure and function of how the foot works to reduce pressure to different areas. So we're involved with all these stages, but have a different responsibility in each of these subsets. We know that CLTI is dangerous and deadly. 4-year amputation rate is between 1/3 and 2/3 of patients. Within 1 year, 25% of patients with CLTI will have passed away, and by year 5, over 60% will be dead. And we're all familiar with the mortality risk that is worse than most cancers, except possibly pancreatic and lung. So this is a serious problem that oftentimes is overlooked when it comes to diagnosis. Earlier this year, a paper was published that looked at patients who had a foot ulcer and CLTI in 2017. They looked at Medicaid data. And they found that of these patients, there were over 33,000 of them in the Medicare data or Medicaid data. And they found that almost 2/3 of them received no revascularization attempt in the year prior to their amputation. Over 90% of them didn't even have an angiogram before they did the amputation. And when an amputation was needed, half of them were above knee. So we're certainly missing the diagnosis, for one, if we don't even realize it's a problem until they've reached this level, because this didn't just happen in the most part. It had been going on for 20 or 30 years and just wasn't recognized. A little bit on acute limb ischemia. The heart attack, this is a level of ischemia that's an emergency, an urgent problem that has the patient will have severe limb ischemia that requires an intervention of some sort, either an angioplasty, bypass, or possibly an amputation. So this is a serious level. And these are also called major adverse limb events. When you see this in the publication, they're talking about these situations. Patients who have this, 4% of them will die on presentation, and 20% will require an amputation at this level. Now, the problem is, even if the patient survives with a leg, for the rest of their life, their hospitalization risk goes up 7 times. The risk of them dying of a vascular cause goes up 3 times. And the risk of having an amputation goes up to almost 200 times. So having one of these MALE occur is not good. And so really, we should be doing everything we can to keep our patients from reaching this level. Sorry here, me. Okay. I'd like to talk a little bit about how PAD develops. There are basically 4 stages that can occur. Inflammation, endothelial dysfunction, problems with lipids, and then one that we don't talk about much, thrombogenesis. First is inflammation. Inflammation really is a problem with most of the disease states that we run into. Certainly diabetes, hypertension, all this, there's an aspect of inflammation that is occurring. And it affects it in a number of ways. I mean, you get your standard risk factors that we've talked about in the past, but also infections, not getting enough sleep, environmental or other pollution, and even stress. All these things add into the inflammatory process. And when this occurs, it will begin to alter how the arterial wall actually works. And it usually does it by affecting the endothelium, the inner lining of the artery, where we'll see what we call dysfunction of that. Now, the endothelial cells are extremely important for having an artery work appropriately because it has a lot to do with how substances perfuse through it, and it needs to be able to vasodilate and vasoconstrict, depending on the situation. And a lot of this has to do with nitric acid. And the problem is with nitric acid, we know it's important for a number of functions of the body, but certainly for vascular homeostasis it is. And from when we are younger, our amount of nitric oxide that our body makes reduces every decade, it'll be less. So that when you're 60, you only have about 15% of the nitric oxide you had when you were younger. And again, this is extremely important for the endothelium to be able to vasodilate, constrict as needed, and also to help the healing process within. Lipids. Again, I just want to touch on this a little bit. We talk about cholesterol and how cholesterol is bad. And there's a lot to speak about with that. But basically, I think we all know cholesterol is not bad. I mean, without cholesterol, our cells could not have structure. A number of our hormones would not be working. So we need cholesterol to live. The problem is not necessarily cholesterol, but how it's bound together and transferred around the body. So we know there's a number of different types of lipoproteins, the chylomicrons, the VLDL, LDL, HDL, all of these. And we talk about some of them being good cholesterol and some of them being bad. But it's really not the cholesterol or the triglycerides that are in this that are bad. It's got to do with the protein that binds with them that allows them to be to dissolve within the plasma. Because as we know, lipids aren't, they're not soluble in water. So the way it's able to be transferred around the body is by binding with a protein, and this protein is called an apoprotein. And there's a number of different types of apoproteins, but I'm going to talk mostly about ApoA and ApoB, because those are the things I think we need to be aware of in primary care also. ApoB is more associated with the bad cholesterol. These are the VLDL, ILDL, primarily the large buoyant LDL, and the small dense LDL on this. These all bind to a protein that's called ApoB. These are the ones that tend to have more problems when it comes to developing PAD. Because ApoB primarily carries cholesterol from the liver out to the body where it's used. The reverse function, taking cholesterol back to the liver, what we call reverse cholesterol transport, is handled by ApoA, which binds HDL. So really, it's got more to do with the ApoA and ApoB than it does with cholesterol, because cholesterol is transferred between ApoA and ApoB throughout the body. ApoA tends to scoop it up, kind of vacuum it to take it back to the liver, whereas ApoB tends to be more of the one we had problems with. And there's different amounts of either triglycerides or cholesterol esters in the different products. But there is one I'd like to mention because really, we don't hear about it much in our literature. This is the apo little a. This is important because of all of them, this is the one that has the most deadly nature.